Hi, Dr. Sal here with Gut Savior. Thank you for watching me. If you need more information, you can always go to my website, gutsavior.co. We also have the same handle for a YouTube channel. Today, what I want to talk about is an investigative tool that gastroenterologists have in their repertoire to help diagnose certain conditions. So many patients come to me and tell me that everything is done. I still have difficulty with this and that. And for example, I have swallowing difficulty and they call it dysphagia. They did the endoscopy, everything was normal. They did the upper GI barium test, which is the dye test to look at the x-rays, and structurally everything looks fine. They said there was no reflux disease, there is no EOE, which is a kind of allergy in the esophagus. And they said that, and there are still symptoms. I cannot swallow and food seems to get stuck, or I cannot burp because it feels like my burp is stuck. So what are these things? Why am I having these little bit of bloating here and those symptoms? So what you need to find out, and you ask the doctor, you ask your gastroenterologist, that is there esophageal manometry or motility studies that can be done for me? That's the question you want to ask. Because if structurally nothing looks wrong, okay, your esophagus is looking healthy on endoscopy and on upper GI barium study, but you have these ongoing symptoms, you may need manometry studies, esophageal motility studies. So what is motility and manometry? What they do is it measures the contractions, it measures the pressures inside your esophagus. Based on that, several diagnoses can be made. So it is possible that your esophagus is so relaxed that it is not contracting, not having regular peristalsis. And that is the reason why you feel that slowness or the feeling of getting stuck. Or you have such intense spasms of the esophagus that the esophagus contracts so strongly that it doesn't open up. So if your lower esophageal sphincter, so in our esophagus there is an upper sphincter that tries to open and close, and there is a lower sphincter that opens and closes and lets food down into the stomach. So the lower esophageal sphincter could be very, very strongly pressured and tight, and that may be the reason why you are not seeing easy flow or transportation from your food from esophagus to stomach. Maybe that's where the problem is. But that lower esophageal sphincter pressure needs to be measured. That measurement, again, with the upper esophageal sphincter, maybe your pharyngeal muscles, they call cricopharyngeal muscles, are so tight that they're not relaxing. And if they're not relaxing, that's the reason why you cannot burp out. You cannot release the air by burping. So it gets trapped. So in those cases, we have solution. First, the diagnostic tool called manometry, esophageal manometry. And there is a good color coding graph which measures it. So we take a tube, a very flexible tube which has sensors, a lot of sensors for the pressure measurement, and it goes through the nose. After numbing the nose, it goes down, it stays into your esophagus and measures the upper, lower, and the mid part of the esophagus. And then that is translated onto the screen where the doctor can actually see beautiful, colorful patterns where there's a strong contraction, it changes color into bright orange, and when their sphincter is relaxing, it changes into light blue. So you can see, even as the food you're drinking, they ask you to take sips of water, and as you're taking it, it clearly shows the pattern where the esophagus is relaxing, where it is contracting, where there is a peristaltic movement, and then finally the closure of the lower esophageal sphincter once the bolus of food or the water is pushed out. It's a beautiful test, and it has advanced so much that it can diagnose conditions like achalasia, it can diagnose conditions like retrograde pharyngeal or cricopharyngeal muscle dysfunction. So those are the reasons where you may have or esophageal spasms, or a condition called jackhammer or nutcracker esophagus, where there are such severe spasms that your esophagus is not relaxing. Remember that these things are not diagnosed with endoscopy and biopsy. And you can say, hey, the doctor did endoscopy and colonoscopy and we did upper GI and everything looks fine, but here it is, I am having the upper GI barium can pick up conditions like achalasia at times, because there's a beak-like narrowing in the esophagus and a large esophagus, which is relaxed and not contracting. So upper GI can pick it up, but in order to make a diagnosis for achalasia, then you need manometry study. We call esophageal manometry studies. Not all centers in the world are doing it, but there are many gastroenterologists who are trained to do those manometries, and they can do it. Almost every institution may have one or two such expertise, especially if it's a good institution. So that is something to keep in mind. Sometimes your stomach doesn't empty well, so that's why you're feeling nausea all the time. That condition is called, if the stomach is not emptying well, then it's called gastroparesis. So if there's a problem of stomach and small bowel, where the motility is a problem, the movement is a problem, then that is also taken care of by these motility studies, and we do what we call enteroduodenal motility. And lastly, the same manometry instruments are now used to check and do rectal manometry, which is in your bottom. So if severe chronic constipation problem is what's bugging you, gasiness, and your bowels are not evacuating well, then those the same tube, it's a kind of tube, flexible tube, is put in the rectum, and the measurements are made again of the pressure, the contractility of the muscles, so you can check the neuromotor function through these. Again, it gives you the wave patterns and the forms, the colorful graphs, and it can tell you that how is your internal pressure, how are you when you're pushing it. Sometimes they blow a little bit of balloon inside to see whether your contraction are moving, or you're getting enough of contractions to move the poop out, kind of thing. Through the balloon you can sense those. So those are with sensors, again, very sophisticated, and a lot of Botox injection in the anal area can actually help with these kind of very chronic severe constipation. So this is what my short information is today about manometry and why that is a very essential tool. Besides this, always think of asking your doctors about breath testing, the hydrogen breath testing for different kind of bloating issues. If you're feeling a lot of bloating, it could be because of the sugar malabsorption. So the testing is through glucose mostly. If you're thinking of SIBO, small intestinal bacterial overgrowth, we used to do lactulose, but more preferably glucose is what you're given enough, and then once it's digested, fermented, you release carbon dioxide, and through the breath the hydrogen is measured, the content, and they can tell with the test results you're having SIBO or you're having malabsorption of the glucose. So one of the ways it can be also tested is whether if you have sucrase deficiencies or lactase deficiencies, that you are becoming lactose intolerance or sucrose intolerance. Always ask the gastroenterologist that when you're doing my upper scope, can you also do make sure that there's no celiac disease, but also make sure you do the disaccharidase enzyme assay. So disaccharides are the enzymes, the sucrase, isomaltase, and they check for lactase and all those things. If you are deficient, then dietary control can relieve you from all these bloating symptoms. If it is because of the malabsorption, because of not having sufficient enzymes in your body. So those are again some of the tests that you should inquire about. Again, imaging studies are also very important in medicine. So people often come and ask me, okay, can we do some x-rays and find out if there is Crohn's disease? General x-rays are not very sensitive. Just taking a plain flat abdomen, we call it kidney urinary bladder or KUB, just a plain film of the abdomen may not give you very many answers. Crohn's disease is a sophisticated disease and it affects the bowel wall. So previously we used to have the dye test. We drink the dye that goes down the esophagus, stomach flows down into the small bowel and enters the colon. So when you look at the small bowels in the last part before it enters the colon, we call it terminal ileum. That's where the Crohn's disease usually starts, and the first part of the cecum. So once it has started there, then you can pick up any narrowing, the swelling of the wall of the bowel or the edema, and that's the way we used to diagnose. Now we don't use that test as much because we have more sensitive, more specific, more reliable tests. MRI, which is MR enterography, we call it MRE, magnetic resonance enterography, that can actually pick up not only the narrowing in the small bowel or the terminal ileum, but it can also pick up if there is any abnormal connection. We call it fistula, like one bowel is actually created a hole and is entered into another bowel. We call it fistula, like a connection. And that sometimes happens in Crohn's disease because Crohn's disease goes through the whole thickness of your bowel. This is unlike ulcerative colitis, where it is mostly superficial inflammation inside the bowel, and the inner linings are affected more. But the ulcerative colitis does not invade your whole colon bowel thickness. So Crohn's disease is tricky that way because it can have fistulas, and sometimes the fistulas open up in the bottom, in the anal area and in the rectum area and through the skin, from the rectum into the skin, from the rectum into the vagina, those kind of fistulas, or into the bladder. Those are pretty serious issues. Now we have treatment for those fistulizing diseases. But we started off with investigations. So yes, endoscopy, colonoscopy can all help diagnose. But imaging-wise, x-rays are not going to cut it. MRE, as I said, can pick up Crohn's. So those are, again, imaging studies. Ask your doctor about those things. Like, what about MR enterography? Can it help me diagnose Crohn's disease? Capsule is very, very important. If you're having blood in the poop and your doctor has done endoscopy and colonoscopy and they cannot find any place why you're having dark, black, tarry stool, which is positive for blood, microscopic blood or occult blood. Why are you having that, and why are you having iron deficiency anemia when the colon is completely clear and the upper GI on endoscopy is completely clear? Now remember, both endoscopy and colonoscopy are good, but they cannot reach your central part of the small bowels, which if you stretch, can go from one end of the living room to the next wall. It is that long. You have 11 to 13 feet of these intestines where your scope doesn't go. So the camera doesn't reach each and every part. Luckily, wherever it goes from the mouth into the duodenum and in the colon all the way to the terminal ileum, you can pick up a lot of diseases. Yes, but you're still missing the central part of the small bowel, the 11 to 13 feet. How are you going to find out if there is any bleeding going on in there, since the scope is not long enough to go there? So there is a way, and you take it's called capsule endoscopy. So we have now a pill cam, a camera which is inside a capsule that you just swallow. And as the capsule is traveling down your gut all the way, it is taking thousands and thousands and thousands of pictures. It is floating. It's a real live thing. You just swallow and you go about your business and poop it out. And you don't have to return the capsule. The poop, it takes care of it, the toilet flush, and it's gone. But in the meanwhile, the images have gotten to your doctor's computer. That's the fancy thing. And your doctor will spend about 2, 3, 4 hours looking at these images and may find a focus, like a polyp or something in the small bowel from where the bleeding is happening. And that's why you're anemic. So again, ask for pill camera study when you're talking to the doctor. If you have obscure bleeding of some kind from the gut and there is no answer from endoscopy and colonoscopy. So again, remember, just because your gastroenterologist has done your endoscopy, colonoscopy, and an X-ray or CT scan and just said, hey, everything looks great, I don't find anything, then you ask about these studies? How about the breath hydrogen testing for me for my symptoms? Would that be a way to find an answer? How about manometry studies, doctor? About GI motility studies, rectal and esophageal manometry or motility studies? How about nuclear medicine study for gastric emptying to find out if I have gastroparesis, which is failure of the stomach to empty out completely, and it retains a lot of food and it's very slow to empty, and that is the reason you're feeling chronic nausea and these symptoms. And again, ask for MR enterography if you're suspicious for Crohn's, and the pill cam if there's some kind of anemia or bleeding, and the sucrase, isomaltase, and disaccharidase study during endoscopy. When they are taking samples, they can take a couple extra samples from the small bowel and send it to pathology to find out if you have enough lactase, if you have enough sucrase, if you have enough maltase. Maybe you don't have those kind of enzymes enough, and that's why you have symptoms. So talking to the doctors are humans after all, and if you are more proactive, you're gonna get your answers. So that's where I'm gonna stop. Thank you all for watching, and thank you for following me on my Instagram, Gut Savior, and visit my website if you want one-on-one attention in terms of more sessions to figure out how to talk to your doctor and how to get your health back on track. Again, I'm not going to treat you, but my guidance might help you in taking you to the right path and bringing you to the answers you're seeking. Thank you again.